For the next session, we will have a discussion entitled Hands on the Hip. We'll be discussing about regional anesthesia for hip surgeries. To address us on this topic, we have Dr. Amjad Maniar. Over to you, sir.
Good afternoon once again, and this session is about the hip, probably as important as the focus that we give on knees. There is a certain role for the anesthesiologist in the outcome of hip fracture surgery, and we'll go through that in the following slides. So what we're going to look at in the next 15 minutes is some clarity on regional anesthesia in hip surgeries, what kind of blocks you should be performing, and mainly when they should be delivered and why. So when we say hip fracture or surgery around the hip, it's a very vague term, and in this day and age, I think we should be very precise about what we're trying to address. There are various kind of hip surgeries that happen around the hip joint. You've all heard of hemiarthroplasty or partial hip replacement. Usually this is done for surgeries that involve fractures around the neck of the femur. You've heard of dynamic hip screws and proximal femoral nails. These are surgeries done for fractures around the trochanter and a little lower down on the upper shaft of the femur. And then you've heard of hip replacements. More often you see hip replacements done in patients of having arthritis of the hip joints, but sometimes you'll see them being done for fractures also. And this is also done on fractures that don't really involve the acetabulum. It's when you have patients who are elderly and mobile, the surgeons may just choose to do a hip replacement over a hemiarthroplasty. Of course, there are some other surgeries that happen like core decompression, and hip arthroscopy is gaining in popularity. But most of the time our focus is going to be on the hip fracture patients. So the reason being, hip fractures are a significant cause of morbidity and mortality in the elderly. And even with surgery, the incidence of post-op complications is quite high. Some of the old data would show that the mortality in these patient groups could reach up to 30% in the first year after surgery. And in India, the approximate number is about 1 million surgeries a year for hip fractures. So that's a fair bit of patients. Now, there's some challenges that we face. Any of you who have anesthetized an elderly patient for hip fractures, you know that they are never ASA 1 or 2. They're usually beyond that. Almost 70% of them are ASA 3 and 4. They have different issues: coagulopathy, difficult spines, difficult to position. Surgeons want to operate ASAP, so you don't have that luxury of getting the patient optimized. They want the patient in theater fast, and I'll tell you why. And this leaves you with that limited time. Now, there's plenty of evidence in literature that the patients do better if you operate sooner. And what is that timeline? It is 36 to 48 hours max. So your premise would be that if you have a patient with significant comorbids, if you can't really optimize this patient within 36 or 48 hours, you have to do the surgery. Waiting beyond and trying to optimize them is not going to really be good for them. And these patients, you've seen them in the ward, they have a lot of pain, and the impact of pain is such that these patients do not move their lower limbs, so their risk of thrombosis and embolism is high. Because of pain and existing IHD, you could trigger a coronary event on them. They sit in the bed because of pain, they don't breathe very well, they develop pneumonias, they have insomnia, and they get demoralized. But what is very interesting in this patient group is that pain itself can trigger cognitive dysfunction and delirium. So you might find these elderly patients getting disoriented, and you would run all sorts of LFTs and electrolytes and everything and find nothing. But it is just because of the pain that these patients get pushed into delirium. Therefore, your goal for a patient with a hip fracture should be perioperative analgesia. That is, even before the surgery has taken place or is scheduled, you as an anesthesiologist should intervene and look for preoperative analgesia. Of course, we do the intraoperative and postoperative analgesia, so that's fine. But the focus here should be on preoperative analgesia. Therefore, with a patient coming for early surgery with multiple comorbids, you need to have an early, effective, risk-free analgesic techniques. This is another area that confuses us. Not all patients have the same level of pain after hip fracture. You might find one who just is sitting there quite nicely. Sometimes they even position themselves for a spinal quite nicely. Sometimes it's hard to believe they have a hip fracture. But then there are the others who are just lying still in bed and you can just not position them for spinal. So there is some variance depending on the site of the fracture. So most patients with neck fractures, it's called an intracapsular fracture, so there is some amount of stabilization by the hematoma, they say. So these fractures may not be as painful as a trochanteric fracture or a shaft fracture, which involves a larger surface area. So to use regional anesthesia, you need to know what nerve goes where. So predominantly, the anterior hip joint is the most richly innervated part of the hip, and the femoral nerve, the good old simple femoral nerve, is the most dominant nerve supply. But you look more on the medial region, and you would have some innervation happening from the obturator nerve, when present the accessory obturator nerve. So when we talk about the femoral nerve, we need to know where the articulation comes from, and the articular branches to the hip joint actually arise quite high, sometimes higher than the inguinal ligament itself. So it's important when you give a femoral nerve block that you give it as high as you can for hip joints, as well as use adequate volumes. There are low branches. This happens about 7.7%. Sometimes there's a mix of these branches. So your femoral nerve block, if you're attempting it, needs to span higher than the inguinal ligament. The obturator nerve involvement has come into premise quite recently, especially when the descriptions of the Peng block came through. So this is more on the medial side. Therefore, the Peng block, which encompasses both the femoral as well as the obturator nerve, has gained in some popularity. But what about the sciatic nerve, or what happens at the back of the leg? So it's a little different. The density of nociceptors is not as much in the posterior side. The sciatic nerve does supply the yellow area that you see over there, and there is some involvement from the nerve to quadratus femoris and the superior gluteal nerve. These are all branches of the sacral plexus, which you saw anesthetized today. Therefore, if you want to get complete analgesia, if required anesthesia around the hip joint for hip surgeries, you must perform the sacral plexus block. This is also the reason why you might have given you see a patient with hip fracture on your table, you've given a fantastic femoral nerve block with volume and concentration, but when you sit them up, they still go ouch, oops, or they struggle. So they don't have complete anesthesia of the joint unless you throw in a sacral plexus block. So the ideal characteristics of a regional block for the hip should be easy to perform and commensurate to your skill. Minimal change of position. You don't want to move a patient around with the fracture and trouble him more. Effective analgesia at rest and movement, and you'll see this come into play because it is fairly easy to create analgesia at rest, but most of the techniques that we do not give great dynamic analgesia. and your analgesia should span the entire perioperative period. So you might think, can I throw in a few conventional intravenous analgesics and get away with it? Well, the NICE guidelines does recommend that you can use paracetamol and not NSAIDs, but we know that there are certain limitations with what you can do with a bottle of paracetamol. So what options do you have? Of course, the central neuraxis is there. You can do spinals, you can do epidurals. You saw Dr. Gopal perform lumbar and sacral plexus blocks, but they are certainly not easy, and not all hip fracture patients are maybe candidates. In fact, if there's a coagulopathy, you may not want to do these blocks. The fascia iliaca block, again, easy block and recommended across many regimens these days. The femoral nerve block, very easy to perform, probably the first block you all have ever done, and a newer block called the Peng block. Two other blocks, the erector spinae block and the quadratus lumborum block, have been used, but I'm not going to span across them because they are a little controversial. So central neuraxial blocks, let's look at the preoperative period. Can we use them? Can we do maybe a little spinal opiate or maybe throw in an epidural catheter? Yes. Can we use it intra-op? Definitely yes. Can we use it post-op? Definitely yes. So central neuraxial block is viable. It provides excellent and complete analgesia of the hips. You don't need to worry about which nerve is coming through. But it's very difficult to position the patient if there's a hip fracture. You may already know this. Technically difficult in the elderly spine, especially if you're trying to do it in the pre-op period. They've called you to ER and you're trying to do it. It's going to be difficult. And the limitations with anticoagulation are there. Of course, if it's a very frail patient, you may have hemodynamic issues. Lumbar plexus block, it's one of the most reliable ways of blocking the LFCN femoral and obturator nerve. Yes, you could do it in the preoperative period if you could turn the patient to the side. I'm not sure what happened. I thought I was going all right. Oh. I think they're missing a few panels on this side. Okay. So, yeah, the lumbar plexus block, you can use it intraoperatively. Dr. Gopal said that they use this a fair bit at his center to provide anesthesia for surgeries on the hip. And post-op, yes, it's a decent place to put in a catheter. But it's difficult, like I said, difficult to position the patient. Unless you're Dr. Gopal, I don't think you would want to really do this. And again, the anticoagulation issues are there. Okay, and of course, if the patient is very frail and you're trying to add a sacral plexus to this, your volumes and concentrations of local anesthetic are going to go high, and these patients may be subjected to issues with LA toxicity. Fascia iliaca block, again, very popular, recommended across many guidelines. You can use it pre-op, you can use it intra-op for analgesia, definitely not for anesthesia. And again, you can put in a cath, or you can do the block for post-op analgesia. It's superficial. And the best part about these blocks is you don't need to reposition the patient. The way they're lying, anywhere in the hospital, you can put in a block. The only issue is it requires about 40 ml of local anesthetic in the suprainguinal approach to work. And though it claims to block many advocates say that it blocks the obturator nerve, this is very erratic. And there are times where people have even missed the femoral nerve while providing the fascia iliaca block, so that's totally uncalled for. So I'm going to skip past the video. Okay. So like I said, there are many studies that actually question the role of the fascia iliaca block reaching the obturator nerve. At the most, it is 67% of times. So again, you take it with a pinch of salt whether you're going to hit the obturator nerve, but what you're looking for really is the femoral nerve blockade, and you can't miss that. Of course, there are some papers actually questioning the role of the obturator block itself in a hip fracture. What about femoral nerve block? Easiest block to do in the book. Provides pre-op analgesia, intra-op analgesia, and post-op analgesia. Again, superficial block, no patient positioning required, easiest block in the world. Does not block the LFCN and obturator, but if you're having a closed fracture and you're trying to provide analgesia, you don't really need the LFCN for pre-op analgesia. And unless your incision is on the LFCN territory, it's something that it's not the primary thing that you're looking for. You're looking for a good femoral nerve block. And with decent volume, it seems to do a good job. In my practice, I still recommend we just do a simple femoral nerve block, dilute your local anesthetic so that you have volume 20-25 ml, just as much as you want, and let it set in there. It works. Give it some time to cook, and it's good for patient positioning before surgery. Peng block is very interesting block which targets the articular branches of the nerve as they traverse over the iliopubic eminence of the hip joint. So the idea is, again, you have a very site-specific analgesia. You don't experience a motor blockade of, say, a femoral or a fascia iliaca block, and it basically just targets that little area where the articular branches enter the hip. So it's been used for preoperative analgesia. It's been used for intraoperative analgesia. Suppose you're doing a GA and you want some augmentation from your regional anesthetic. It does provide something around the hip joint. And of course, postoperative analgesia, it has been used. Once again, attractive because you don't need to specially position these patients. And the success rate, again, it's a little dodgy. Some people like it, some people don't like it. The pain scores at rest are quite good. Dynamic pain movements, again, little questionable, but this is definitely an option you have. Some people I know are placing catheters in this area and continuing it several days into the post-operative period so that the hip movement pain is reduced. So again, it was a new block. It's been around for about I think maybe 7 or 8 years now, and still a lot of studies going on. So this is an image from one of those original articles that showed where the neural structures are. Let me just point that out. It's somewhere over there that you're trying to. Yeah, somewhere over there that you're trying to deposit the local anesthetic and block just the articular branches. And this is the cadaver images of what really happens. So if you're wondering whether regional anesthesia actually benefits outcomes, overall outcomes compared to GA as an anesthetic technique, there are some articles that look at this, but it's very marginal. It's like sometimes a wrong message is sent that neuraxial is the way to go and it's the only way to go. It's not really that. You need to look at the patient overall. There is a slight benefit, but probably just numerical. What do people say? So the surgeons, the American Association of Orthopedic Surgeons actually recommends regional anesthesia in the pre-op setting. So it's nice when your surgeons are actually recommending RA. So this was another paper that looked at a review of analgesia and pain modalities in hip fractures. So the femoral nerve block is superior to IV morphine. So you'd probably want to do that rather than give morphine. Fascia iliaca block and femoral nerve block are fairly the same analgesia, which is again the fascia iliaca block predominantly being a femoral nerve block, an indirect femoral nerve block. So the lumbar plexus block is probably better than the fascia iliaca block for analgesia, but again, all of us are not Dr. Gopal. Epidural catheters provide superior analgesia, especially during dynamic movement. So if you're really looking at how the patient is going to be moving post-surgery and post-hip fracture surgery, you're probably still going to look at the epidural. Intrathecal opioids, if your patient is younger, probably yes, but we don't use intrathecal morphine much in the elderly and the compromised. The prospect guidelines back in 2010 recommended the femoral nerve block or the posterior lumbar plexus block, but for total hip arthroplasty, but now that's changed. They're recommending the fascia iliaca block or LIA, probably because of the frailty of these patients. So how do you approach this? I'll just finish this off soon. The goal is to reach pain relief at rest if the surgery isn't delayed. So this is just a schematic as to how you would want to think regarding the patient. So you look at your pre-op situation. Of course, the welcome drink in most hospitals is paracetamol. If it's a younger patient, maybe NSAIDs or a weak opioid. And the goal being pain relief at rest. Okay, we are not going to ambulate these patients, so dynamic pain is not an issue here. If that doesn't work, you're looking at, say, maybe a femoral or a fascia iliaca block. So your regional anesthesia options, I've laid it out to you before. So if you're taking the patient intraoperative now, your options are going to be either the femoral nerve, a fascia iliaca block, or a PENG block. If it's going to be for anesthesia, surgical anesthesia, then your options are limited to the spinal epidural or lumbar and sacral plexus. Okay. And in the post-operative period, again, you're going to probably continue your paracetamol and NSAIDs, but here you're going to look at dynamic pain relief after surgery. So you'll have to take that into consideration depending on how your surgeons want the patients to ambulate. So basically, if you want one single technique to span the entire period, then it would be to put in a nerve block catheter. If it's going to be an epidural, so be it, or a lumbar plexus catheter, be it. What we have done over the years is we have placed femoral nerve catheters out of plane and pushed them all the way up, and bolus these. We can place them in the emergency room, bolus it, wait for the patient to arrive for surgery, whether it takes 24, 48 hours. Intraoperatively, if you're doing a spinal, just spinal him. If you're doing GA, then you just bolus the catheter with a more concentrated local anesthetic and continue running the infusion in the post-operative period. And this has worked for us, but then you can make guidelines based on your institution. So in the end, management of the hip fractures can be, in the elderly, can be challenging. So the key point here you would take home is to probably provide analgesia before, during, and after the surgery. So no particular RA block has a very significant advantage over each other, so you choose wisely based on your skill and experience in that field. If a femoral block is all you can do, please do it. So, and the other point here is this is one set of patients where you would get involved in pain management well before the surgery with regional anesthesia. Thank you.
To continue with the panel discussion, may I please request Dr. Nitin Heron to take over as the moderator. Dr. Deep Arora, sir, on the dais, Dr. Anuj Jain from orthopedics, and Dr. Ankur Das. And from physiotherapy, we will have Dr. Pradeep Chaudhary, please. Over to you, sir.
Thank you, Dr. Devyani. So, good afternoon, respected panelists. Nice lecture, Dr. Anand. I think most of the things might be a little bit clear with his. Just we will go with the practical approach, how the surgeons take on this and how the post-op physiotherapy they go for this post-operative pain. So now, as also touched by Dr. Amjad, that the recent literature, that mostly the REGAIN trial and the RAGA trials have said that spinal is not better than GA, or GA is equivalent to spinal. As when we compare the primary anesthesia technique for the geriatric patients who are undergoing hip fracture surgeries. So Dr. Deep sir, what is your take on this? Do you still prefer Durexgel or you use both?
Is this for anesthesia or analgesia?
For anesthesia, sir, primary anesthesia.
Standard practice at my center is a spinal. We don't do epidurals
Okay,
at all.
okay. So Dr. Amjad, sir?
So we'll have to look at in what context it's being done.
So
sir.
basically, geriatric age group undergoing hip fracture surgeries, you like the recent NEJM article and other articles have said that now, earlier we were thinking that spinal is better in terms of mortality, in terms of thromboembolism, in terms of cardiac failure and other 30 days mortality. But the recent literature have said that now they are equivalent. So have you changed your practice or still the spinal you are using?
So whenever possible, it's the spinal.
Okay,
But I wouldn't worry about putting in a GA
okay, okay. Thank you.
because there are specific contraindications sometimes to a regional
That are
anesthetic,
that
and
are
there is
that
nothing
are
for
there.
GA.
Okay, okay, okay. So any consideration from the Dr. Anuj or Dr.
See, for us, it is the post-operative pain and efficient physiotherapy program, and we leave everything to the anesthetist.
Okay, thank you.
In all our patients who come to the emergency initially, we prefer to put a femoral block there to block the pain so the patient is comfortable. Then in the operative period, we always prefer spinal anesthesia. And then in the post-operative period, we usually give intravenous fentanyl for a day or two.
Okay. So this is for Dr. Amjad. So do we still go for an epidural for when we plan for post-operative analgesia for THR mostly, or you are now doing more of the peripheral nerve blocks when you are planning for epidural for post-operative analgesia in THR patients?
Okay, so there's no doubt that the quality of analgesia from a central neuraxial is going to be better from any of these peripheral nerve blocks. But with epidural come their own set of issues. For example, these patients will have to have a catheter. Sometimes they don't ambulate very well having all that. They have complementary analgesia and anesthesia of the other leg. So these, you'll have to take it in context as to how soon the patient gets ambulated also. There are certain surgeons who probably don't want them ambulated for even 48 hours.
Okay.
So those patients may do well on an epidural, have some minimal passive exercises going on, they do well with
Your
that.
practice is combined both, in some
Yeah,
patients
so
you go for epidural?
it depends on how soon these patients are going to get ambulated. There are some surgeons who want a patient off the bed soon, so then you would probably go for something a lot less extravagant.
So Dr. Deep, what is your take, Dr. Deep, sir? So you mentioned that you don't go for epidural at all
Yes.
in any
we
of your
do.
patients?
Never. For the last 15 years, no.
Okay. So, Dr.
So we do only with peripheral nerve blocks.
Just reiterating, Doctor, what Amjad said, because we actually take, being the surgeon, take a decision as to the level of and the fixation that we achieve. For cemented hip, we want the patient to be ambulated the next day, full weight bearing. For uncemented cases, we might want some delay depending upon the porosity of the bone, the age, presentation, indication and all. So it actually it is dependent on the indication of a THR.
Okay. So depending on the procedure that you have done, you will plan your ambulation in the post-operative
Not a
period.
hard set
Okay.
rule.
So Dr. Ankur, sir.
Anuj.
Dr. Anuj.
Yeah.
So, Dr. Ankur. So do you do revision THRs?
Yeah.
So are there any difference as we compare the post-operative pain with the primary arthroplasties?
The anesthesia during the surgery will change. Most of the primary THR will be under spinal anesthesia, and division THR will be under CSC.
Okay.
So as we are providing epidural analgesia, most of the post-operative pain will be less because we can do the top-up and get the pain relief.
So how's your experience in the post-operative period with these revision patients?
The only thing we need to worry is that we need to be aware about the quadriceps power. Most of the patient when you give the epidural analgesia, we have a lot of quadriceps power, and they have a tendency to fall. So before mobilization, we always instruct the therapist, please check the quadriceps power and then only we mobilize it.
Okay. So Dr. Deep,
This is
sir.
one challenge that we face. We need a very strict and titrated regime for epidural so that the physiotherapy and rehab program does not it's a basically
A balance between analgesia and physiotherapy for all joint replacement patients. So we sometimes have a situation when they have such good analgesia, but along with this means the motor power, the suspension, so that we are not able to get the patient out of the bed.
So Dr. Deep sir, do you plan differently for revision THR patient or the same as the primary hip replacement patients?
Sir, I'm fortunate to work with an excellent surgeon whose revisions have never taken more than 90 minutes, most complex of cases.
So
what we do,
remain the same.
So what we do is we use clonidine intrathecally. So it prolongs the duration of good anesthesia for minimum 4 to 6 hours. That is more than enough to cover all of our surgeries.
Okay. Thank you, sir. How much clonidine?
How much clonidine? So clonidine we use 15 micrograms in a healthy patient or very frail patient 7.5. Anything more than that, we started with 30 mics, but then we used to have more hypotension, more bradycardia. With 15 and 7.5, these are not any issues because we also run dexmedetomidine along with the intravenous. In spite of this combination, there is no incidence, a higher incidence of brady or hypotension. Sorry?
Any age group you restrict yourself from the
Clonion, no. Yes, even 80 plus, 88, 90, yes, I've used. But the dose will be less, 7.5. Intrathecally, I have not used because clonidine is a much cheaper option and it serves as well.
Not recommended also. It's not recommended by, not approved.
Not
for
FDA
intrathecal
approved.
approach.
Yeah.
So this
This
is for,
dexmedetomidine is a pure alpha-2 blocker, I guess.
So as I said, it is much cheaper and not FDA approved, that is one thing. But personally, I don't have much experience with Dex intrathecally.
Okay, sir. Thank you.
So this is for Dr. Ankur. So there are a lot of approaches that have been described for total hip replacement. So like American Association recommends that anterior is now much more better when we talk about the post-operative recovery, pain, as well as the outcome of the surgery. So what is your recommended approach for the THR? You go for anterior, lateral or posterior lateral?
We actually, see every surgeon, there are so many approaches and it all depends. A good approach is actually surgeon dependent. If a surgeon is adept and very much experienced in a particular approach, he will do that surgery with that approach better. So I prefer a modified Harding's for my for my THRs, but posterior approach has been in vogue since decades, and this direct anterior approach has recently been has been taking much popularity. The patient is supine and you can do bilateral cases in one sitting, so those are the advantages. But I have limited experience with direct anterior.
Sir, your experience on this?
We almost do all of our hips by posterolateral incision.
Okay.
And it's always surgeon dependent. We do anterior or posterior, doesn't matter. The good approach matters.
Okay.
And we haven't experienced any differences in the pain management in both the approaches.
Okay. 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 So, sir, when we plan post-op analgesia, Dr. Amjad, so when we plan a block in the post-operative period, so do we mostly concentrate on the osteotome, or you take consideration for the myotome as well as dermatome? Because if you see, so the posterolateral approach involves a lot of other nerves like iliohypogastric, and anterior will have this femoral branch of genitofemoral or cluneal nerves or so what is your, how do you plan your block whenever there is, suppose orthopedician is doing a posterolateral approach for the...
So in the immediate post-op period, shortly after your primary anesthetic has worn out, all these things, the dermatomes, the myotomes, the osteotomes play a role. The role of the dermatome and the myotomes actually subside much quicker than the osteotome. And the next thing is, if this is a hip fracture, actual fixation of the hip fracture itself is an analgesic technique. The thing. So what comes into play is the dynamic pain, that is when they start moving, how they manage on that. So if you are not, sometimes if you look at these nerves, you might start going and chasing all the little dermatomes, which may not be really, the thing that you want to do in these cases. So there are various other things to do to deal with this. There's in fact local infiltration analgesia which can address both the myotomes and the dermatomes quite well, and that can be also supplemented. You can suppose you've done a femoral nerve block or a facial block, and that's the only thing you can do at that point. You can ask the surgeon, give the surgeon 20 or 40 mils of 0.2% ropivacaine and ask him to infiltrate the muscles, the skin. So these are options rather than sometimes chasing these roles and chasing these nerves and setting a precedence on
so
some
basically
difficult
take home
things.
is if you can go for the lateral cutaneous, you can go. Otherwise, there is no need to chase the small nerves.
Yeah, so even if you can't do a lateral cutaneous nerve and you really
just
want
go
to
for
do it, just give the surgeon some local. It's a
Infiltration.
cutaneous nerve, we can
Okay. So that is
do that.
what we also do. So Dr. Deep sir, anything you want to add on this? Right.
For post-op analgesia, like in Dr. Gopal's center, if our patient is very moribund, EF of 20% or less, very frail, and we put in a lumbar plexus block which carries on for post-op analgesia. Otherwise, in majority of patients, our standard practice is CFI, suprainguinal fascia iliaca continuous catheter, which takes care of the LFCN territory, where most of the incisions lie. And like Dr. Amjad said, the other dermatomes, it is much less painful. Hip surgery is much less painful than the knee. So a multimodal takes care of the rest.
Just wanted to emphasize on this.
Yes, yes.
So the next question is Dr. Ankur. So how soon do you ambulate your patients after THR? So what is your practice in? You have already told me, depending on the implant you will.
Yes, cemented and uncemented, we take some variation in decision, but the emphasis is on weight bearing the very next step. Partial weight bearing, walking with a walker, along with assistance, with physiotherapy.
So you wait for 24 hours?
24 hours, yes.
Dr. Anuj?
Yeah, wait for 24 hours for mobilization of the patient. From the second day onwards, they can walk full weight bearing with a walker. And from progressively we can come on the fourth day we start climbing stairs.
Okay. So Dr. Pradeep, perspective of that physiotherapy PMR. So what is your take on this ambulation? So how soon you want?
So generally we ambulate patient after THR surgery around 24 hours of surgery.
Okay.
So we ambulate the patient, sir. So with the help of walker to provide more stability, sir.
So how important for you is the so post-operatively there should be some motor power in
Yes,
the
sir.
whenever
Yes, sir.
the patient is you are ambulating, you are doing the exercises.
Yes, sir.
After 24 hours. How important for you is, so you do for a passive or do you go for an active exercises in the first 24 hours?
Yeah, first 24 hours. sir.
After the first 24 hours.
Yeah, we go with active assisted exercises program, sir. Active exercise program, sir. No passive exercises, sir.
Okay. So you want the motor power to be there.
Yes, sir.
Okay. So sir, what can we go for? So I think femoral and lumbar plexus is out when we talk about the motor sparing block. So Dr. Amjad, what is your preferred motor sparing block for this?
So it's going to come down to the PENG, isn't it? Even then, the PENG block, if you exceed the volume, there have been reports where the femoral nerve gets blocked. It just goes all around and it comes back to the femoral nerve block. So apart from the PENG, the other popular modality, I dare say, is LIA for the hip joint, local infiltration analgesia. If motor power is that much of an importance, that is another option that you have where you give large volumes of local anesthetic to the surgeons and they will infiltrate all the way around. So apart from that, and to an extent the PENG block, everything else will have some degree of motor blockade, right from the epidural to all the way down to the
So
femoral.
how much volume do you prefer to avoid the femoral nerve blockade by PENG block? Or there is some anything
So-
you do specifically in your technique so that
So-
you don't block the femoral nerve while doing the
Yeah,
PENG
so
block?
there are two things that you would do is one, have a proper visual endpoint that you don't exceed the certain volume and see the local anesthetic spreading all over and along the, the iliacus. The next is to have, like I said, a set volume, about 12 to 15 mils max is I think what you would do
so-
for a PENG block, probably.
So Dr. Deep sir, so are you going for a motor sparing block or sci-fi? You are happy with sci-fi?
We are happy with sci-fi in the sense we use 0.2% ropivacaine, and which in our experience has not hampered with the ambulation, because remember these are not full weight bearing. Most of the time they walk with some kind of help, a walker, or it is, I don't know when you do full weight bearing within 24 hours or with a walker, right? So that is why there is some kind of support. So they do quite well. With PENG, if your needle endpoint is too much medial, then it is more likely to spill over to involve the, and of course the volume if more than 20 ml, yes, like
One
Dr.
thing I
Amjad said.
had, I was going through an intramuscular, so the
Intramuscular,
it has to
again,
be
yes.
in between the plane. It has
Correct.
not to be within the substance of iliacus. So
Absolutely.
that is one more important thing.
Yes.
So apart from that, now like Dr. Amjad also mentioned that there are QL and ESP also coming up for post-operative analgesia. So sir, any experience for hip surgery with QL?
QL no, but ESP plenty.
Okay.
We do ESP catheters for post-op analgesia. In those extensive surgeries where you remember, we have to keep in mind PENG has its limitations. Like Dr. Amjad pointed out in his lecture that these are the articular branches which are getting covered. So anything beyond the trochanter, distal to, will not be covered,
Obviously.
right? So similarly, the LFCN territory is not being covered. So it is a good block. We utilize it more in the pre-operative, like he said, when optimization, sometimes once in a blue moon, patient is in frank failure, cardiac failure, you need 2 or 3 days to decongest. So there we put in a catheter for in the PENG. But otherwise, ESP for very extensive surgeries has done very well for our knees and hips.
Actually, literatures have the randomized trials have come up for this QL also for hip surgeries, and they have found to be good. So I was going across a article on RAPM 24 only. So they have found no motor, but they were not patients, they were only young adults, and there were no motor difference in the the normal block limb and the unblocked limb. So that was one of the thing I wanted to share with you all.
Which approach was this?
Anterior approach, suprailiac QL anterior approach. So I think we have already have the answer. What will one block that you will prefer for hip surgeries? I think everybody is clear on this. You want to change?
Let's see what the audience says.
So you can just emphasize one more.
Maybe we can take a survey. Okay, how many of you says the one block for hip surgery is going to be an epidural? Okay, no answers. Lumbar plexus? Dr. Gopal will raise his hand.
Sci-fi oblique PENG. Sci-fi?
Okay.
Okay, and PENG?
PENG?
So some people...
Femoral?
With both.
Okay, there's some femoral takers. There are 2 hands. Okay.
Okay. So, thank you. So, now arrival block, or you can say for positioning of for spinal?
Yeah, again, it's going to be whether, what is comfortable. I still do a femoral. The sir does a FICB, and it's there on many of the recommendations that the block on arrival should be a fascia iliaca. I still prefer to do a femoral. I think old habits die hard. And it's also, if you were to teach a junior and these patients will arrive in the middle of the night and your junior most person is on call, and femoral would probably be the first one I would have taught them. So I just tell them to do a femoral rather than explain them how to do a fascial. Again, it's a practice thing. It's probably not very different.
So suppose
for a block
now
on
the
arrival. Because in an arrival block, you don't need LFCN. You don't need LFCN at all.
So for spinal positioning, which one you prefer?
I still do the femoral in my practice.
So which is, I
don't.
think...
But it's not that I'm recommending you do a femoral. It's just that my practice is such that we just do femoral, we add 25 mils.
My practice has been now changed to PENG. So I usually go for PENG for most of the positioning, for positioning the spinal, for spinal anesthesia. So I think American Association doesn't recommend for catheters for THA post-operatively because there are chances of falls and other things, and because of the numbness of the continuous plexus, there is proprioception, there is a hampering of that. So, but sir, what is your approach if you are planning for a continuous catheter in the post-operative period? Suppose the patient is having a lot of pain in the pre-operative period and you have planned for a post-operative catheter. So which approach do you think should be?
So number one is the Americans have far better opioids than we do over here, and that is a different problem that they have also with it. So our limitations in our country are definitely going to be that, and we're looking at it's still, again, I'm still sticking with the femoral. I haven't done the PENG catheter. I've done PENG blocks, but I've not done a PENG catheter. But I just was talking to a friend recently who kept the PENG catheter for over 2 weeks.
We keep it for 24 to 72 hours. So
yeah, that's the usual duration of a catheter, but people are going to that extreme so that, they are able to do the post-op physiotherapy very well. So probably that's another one that can come in. Of course, the cath is going to be very advantageous even if you're doing a SIFI because of your ability to give low concentration local anesthetic. That is the real advantage there, because with a single shot you're going to hammer as much as you can in the first thing and hope the block lasts. But with the cath you can just go on and on with a very dilute local anesthetic, and if you do get quad weakness you can still further lower it down. Even from 0.2 you can go down to 0.1.
Okay. So Dr. Pradeep, should we be concerned with quadriceps weakness in the post-operative period? Suppose the patient is on continuous peripheral nerve blocks, okay, and he is having a quadriceps weakness. So how will you now manage your physiotherapy part in the post-operative period?
Ideally, we go with the isometric exercises.
Okay.
So that play a major role for muscle activation, and we make them mobile with the help of assistance. So the chances of fall is very less.
Okay. First of all, I think we should.
It is a concern.
It is a concern. So first of all, I think you should be stopping the infusion. Then only recovery of the quadriceps will be the first and foremost thing. So, any role of sir already had elaborated on. So mechanism of action, sir. So something about the mechanism of action of lumbar ESP, sir.
I don't know, honestly. But all I know is that it works. And I'm not talking about 5 cases or 10 cases. I'm talking about nearly 100 cases of lumbar or sacral, different levels of ESP, or even higher up in T1, T2 for neck and shoulder. It works. That's all I can say.
So it's working nicely.
Absolutely.
So I was going across a literature, and now they are saying that if you are planning an catheter for post-operative THA, so lumbar ESP may be the coming up choice for motor sparing, and if you are planning an anterior approach, so then the catheter will be posteriorly placed, and of that the lumbar ESP should be the first choice. So that is coming up, and I think we are still waiting for the literature to come up for that. So
I have a question for Dr. Deep. Have you used the lumbar ESP as a preoperative analgesic for positioning the patient?
Never.
Okay.
I always use pen for positioning.
Okay.
It's much simpler.
Positioning for ESP, we have to take the patient lateral, so it is not a point of the patient will
No,
have.
the reason is when you have the fracture on board, that is when they have the most amount of pain.
Yes.
And whether, so it's a simple question, can a lumbar ESP provide analgesia to an unfixed fracture?
I don't think so.
This was basically, I was telling about the
It's
post-operative.
post-op analgesia. Yeah.
So that's where I'm, when you have a fracture that's absolutely broken, that's the most painful, undeniably most painful thing.
For that, I think Pang and Sci-Fi is the
But
only
when
thing.
these hip fractures are fixed, there are patients, and I'm sure our surgeons have seen that they probably have worked with anesthetists who haven't given a block. Some of the patients are still okay. They still manage. Because that fixation of the fracture is the single most analgesic maneuver that we are doing for these patients. So that is where you question these facial plane blocks, whether in the setting of pain, intense pain, are they able to do the job like a femoral, like an epidural or a lumbar plexus would do.
Lumbar ESP has been utilized for providing labor energy.
He is the father of ESP in India.
Why people cannot accept it, I don't understand.
But that said, Amjad, the ESP works for analgesia following the hip fracture. It does. So it should work even for the hip fracture.
So that's why I asked him. I'm not getting the answer.
I want to add one thing.
It's working in the post-op period, but your question is very specific, whether it will offer on positioning analgesia.
On positioning, it is not,
So,
it can't be done.
you know, there are so many theories going on with the plasma levels that are attained when injecting into these muscular. Yeah, you're fresh with each and every one.
So I want just to put a point exactly. If you compare the same, if you exactly the mechanism of ESP, if you literally I have done both lumbar ESP versus thoracic ESP. So what we have seen practically is that the spread of the drug is beautifully spread in the thoracic. That normally we don't see in the lumbar ESP. If you see the fascicles of the ESP at the lumbar level is white, even the muscle thickness is also here. So the serrations of that, even if you have 20 or 30 ml drug, it may be very minimal craniocaudal spread that normally we see in the thoracic. That is one thing. The second thing is that I have some experience of lumbar ESP in the patient with spasm, those who come the pain clinic OPD with the chronic back pain. So the moment you give a lumbar ESP or something that in that, immediately the patient gets out of that spasm. That means the myofascial component, that might be because the cause might the medial branch from your dorsal ramus. So if in case of a hip surgery or something, see whenever the patient is undergoing surgery, there is always a myofascial component that is in the hidden is there. So anything that is the muscle pulling or something that spasm is there, and if you are giving a block, so that myofascial pain might be contributed in that way. Second thing is that as Dr. Devesh has pointed out, regarding the ESP, lumbar ESP has been studied in labor epidural. So if you go to the study that is published in anesthesia, I think anesthesia journal, so it basically says that initially they did bilateral ESP catheter. So after seeing in 2 or 3 patients, they started seeing that the patient, if they activate one single catheter, then only the patient is having a pain relief. And subsequently they placed single catheter rather than the bilateral catheter. So that means it's not that you need a bilateral catheter for the labor pain to act. The same paper says that. So one, I think point might be, once you're giving a 20 to 30 ml of drug, there is chances that there might be neuraxial spread of the drug, as I have seen in the sacral ESP. If you have sacral ESP, you see the drug has tendency to spread apart from the dorsal ramus, that the neuraxial spread is there, minimal. So I think that is the thing that might you can in future, if more and more studies come up, the effect or how the mechanism that will be more and more, I think, deciphered. Thank you.
I think Okay, so just the last one. So we have already talked that most of the the nociception is on the anterior part, and most of the mechanoreceptors are in the posterior capsular area. But then also, even after PANG or sci-fi, might be some patients you feel that they are having pain. So are you planning for, like, there are literature mentioning regarding the posterior sacral plexus block or posterior sacral ESP block or posterior like PANG anterior, PANG posterior block?
Yeah, so it's not that we haven't done this. So there are patients who we give general anesthesia to, and you want to reduce your opiate dose, your anesthetic dose. You could put in a block for the front, and you could throw in the sacral plexus for the back to ensure that a majority of the the innervation is covered. So, and as Sir says, for anesthesia, they do a sacral plexus plus the lumbar plexus. So there may be patients where there is a dominant innervation from the back that is a little more than usual, and you find that you've given a good block for the front and they still are very uncomfortable, then you could consider doing the sacral plexus post surgery also.
Do you feel the requirement for this posterior block, so posterior ESP or posterior pericapsular block, sir? Dr. Deep?
Very, very, very rare cases.
So not commonly?
Absolutely no, no.
So, okay.
Actually, in those patients, like for hip arthroscopy, where there is a lot of fluid is infiltrated into the joint capsules. Because of the distension of the joint, there is a posterior pain. In those patients, this might be helpful.
Okay, okay, well taken point.
Point taken, yes.
So I think we are at the, yeah, no, it's okay, you just please.
This stems for, like from the chronic pain literature, they are blocking nerve to quadratus femoris and it gives good pain relief. So this is stemming from their literature to our literature, and Dr. Sanjay Sinha is working, he calls it as a sub-Q block, and as he said, posterior PANG, that is PPD block, which is being advocated. But for hips, I don't think posterior pain needs to be taken on. Maybe, as he said, hippoarthroscopies I do not do. Okay. Maybe in that case, it might be required because of capsular distension.
So, thank you, Dr. Devesh. So, with this, we come to the end of our discussion on hip joint surgeries.
Thank you, everybody. May I request Dr. TVS Gopal to kindly help us in felicitating our faculty?
In the field of joint replacement, where a lot of work would be solicited, means it is required.
Let me keep the
It is required. And the one concern
at times
is basically post-op. The patient is suffering because of the arthritis.
Dr. TVS Gopal, sir, to kindly felicitate Dr. Deep.
To undergo a surgery is post-op. A lot of work. I mean, we should do more and more so that it does not, there is a large group of patients who say,
Thank you, sir, for your most gracious presence.
so that they are more, this is one challenge that we face. Post-op phase.
Dr. Nitin Haryan.
Yeah.
Dr. Anuj Jain. Thank you, sir. Dr. Ankur Das. Thank you, sir.
ये माइक नहीं चलेगा?
And Dr. Pradeep Chaudhary.
ये ठीक है? आइए.
Thank you, Dr. Gopal.